more than thousands we have crossed in the last two, 3 sessions at instrument class and this thing. And this, I think, is watched by more UG students also, I think, sir. I think
Maybe.
the other things also. And I also would like to take the inputs from the faculty. Like if you could start little bit, there have been some requests from the students regarding standard operations. Like, sir, one by one, you ask them to teach the steps like mastectomy, modified radical, total thyroidectomy, like that. I'm not sure. Please advise. You also think over, sir, how much we'll be able to do justice. I'm sure we'll be able to do justice, but the time limited. We have been from the beginning only doing clinical discussion. Are we to take up the other aspects of the teaching also? You all maybe think over it for 1 week, or we should give purely only impetus to clinical surgery, which we have been doing for so many years now. And please advise, like I'm willing to experiment, but if we are going to touch upon the other aspects of surgical teaching, I'm unsure how much like we will be losing the stress on the clinical teaching. So I request all the senior faculty also give a consideration. I'm willing to say accept a clear no also. Don't feel bad about telling that no, it is not right to merge so many things or take up so many things. But one thing is, this time I was told some difficulty in national board exams also in the afternoon, because students could not perform well in the afternoon. For that, the board of examiners have to consider if they are not performing in the afternoon viva. Actually, we all of us believe that afternoon viva augments the results. But then this time there have been some thing where students could not live up to the standards expected by the examiners. So students have been asking, sir, we would like to have the operative surgery viva also to be covered. Please advise, sir, because this how we can bring in, because that is going to be a long list of surgeries. It is not going to be in 1 day or 2 days, will not be able to complete. So how we can take up, you please advise, sir, so that I will take inputs in the group also. So with that, Dalvi sir, please, sir.
See, operative surgeries cannot be shown. We have been stopped so many times under my presidentship of ASI, and we have had a lot of problems. So operative surgery, you will have to somehow find a way out to demonstrate operative surgeries. That's all that I can say.
Sir, I'm definitely not contemplating live demonstration, sir. It is going to be a video lecture. That is what I'm contemplating.
Even if it is video lecture, if you
yes,
want to show inguinal hernia and penis is shown, it's blocked.
Yeah, the organs. I think what sir is telling is
tomorrow, if you want to show MRM,
yes, sir.
Once breast is shown, it's blocked. So these are the problems which we have faced. To me, as a president of ASI, so
yes,
you'll have to be very careful. They've found out a way to get out of it. Just try and get through the present president of ASI, and we should be able to do it. Thank you.
I will take your word, sir. I'll also have a discussion with Dr. Prabhal and then the present scientific team and take it further, sir. The other thing is, sometime, in fact, we have registered a website for our own PG clinic. So website, I think we can post the videos that I will consider with my own team, hospital website team also, sir. But few times our videos have also been knocked off from the YouTube channel. Now that then we realized the breast and other body exposing areas and all, if we keep less than 10 seconds, generally off late that after that, we are not facing much of censures from the channels. But anyway, full surgery, I think we may have some trouble. Let me discuss with the others also, and then we'll take a call, sir. Thank you very much, sir. And now the permission, we move on to the second half of it. We have been kindly contributed by Professor Sridhar, sir, from Apollo Institute of Medical Sciences and Research, Hyderabad, a case of soft tissue tumor. Professor Sanjay could not join. He has requested that something has come up as an emergency. So we have Professor Mohammad Ibrahim, Professor Priyanka from Mathura, Professor Mohammad Ibrahim from Chennai, and our own faculty, Raj Gopal sir, Sahai sir, and Karnakaran sir, and other seniors here, Hitesh sir. You are welcome to take up. Dr. Narayan, are you with us?
Yes, sir.
Can you switch on your video, ma?
Yes, sir.
You both Shiv and Narayan. Very powerful person.
Yes, sir.
Right, good. Please share your PowerPoint.
Yes, sir.
Kanna sir, you are outside, sir. Welcome, sir. Make it full screen, Narayan, and please introduce yourself, your unit
Yes,
chief, your head of the department, and start presentation. Faculty, please take over. Good luck to you, Dr. Narayan.
Yes, sir. Thank you, sir. Sir, good evening, sir. Good evening, respected faculty. Myself, Narayan, general surgery resident.
I'm at the airport. Going to.
Please
Sir,
go ahead. Please go ahead.
yes, sir. My guide is Dr. Sridhar, sir. He is professor and head of the department, general surgery, Apollo. And Fayaz, sir, professor, department of general surgery, Apollo. Today, I'm here to present a case of soft tissue sarcoma of left thigh. Uh, Chief complaint to start with, a 20-year male resident of Toli Chowki who is a student came to the OPD with chief complaints of swelling in the left lower thigh for the past 4 months and pain in the left lower thigh since 10 days. This is the clinical image of the swelling. And coming to history of present illness, the patient was apparently asymptomatic 4 months ago when he noticed the swelling in the left lower thigh, which was insidious in onset and initially was approximately 2 centimeter in size and rapidly progressed since last 4 months to the present size. The swelling is painless to begin with and it's associated with pain since the last 10 days, which is insidious in onset and gradually progressive and dull-aching in nature, and it's non-radiating. And there is history of trauma over the left thigh hit by the cricket ball 8 months ago. And there is no history of neurovascular or neuromuscular deficit of the left lower limb. And there is no history of swelling anywhere in the body. And there is no history of fever and no history of weight loss and no history of suggestive of distant metastasis. And past history, he has no known comorbidities and there is no history of radiation exposure in childhood and there is no exposure to chemicals and there is no past surgical history and there is no history of cancer related deaths in the family. And personal history, he takes mixed diet and his sleep pattern is normal and he has normal bladder and bowel habits and he has no addictions. To summarize the history, a 20-year male presented with swelling over the left lower thigh with recent onset of rapid increase in size, which was initially painless and later on developed pain with history of trauma over the left thigh 8 months ago with no symptoms suggestive of distant metastasis.
Please wait. Faculty will ask questions. Ibrahim sir and others, please take over, sir.
Yes, sir. Thank you, sir. Narayan, good evening.
Good
So
evening.
can you go to the first slide, please? We'll just summarize the history and we'll
Yes,
discuss it and then we'll go back.
Yes,
so in the chief complaint, you told it as a 20-year-old male, resident of Tolichoki, student, everything is okay.
yes,
So you have
sir.
not whether the swelling is causing any difficulty in walking, difficulty in locomotion or difficulty in walking, pain in walking, any difficulty in joint movements. So why is it important?
Sir, due to compressive symptoms, sir, as it's present very close to the knee joint, there might be, as the swelling is rapidly growing, it might compress the nerve, any neuro.
No, actually, it is just a swelling. We don't know whether it is infective, inflammatory, malignant, or whatever it is, okay? Or congenital. So you have to think in all aspects. So can you tell me of an inflammatory swelling which will cause painful joint there? So what are the causes of painful joints?
Osteomyelitis, sir, chronic osteom.
Yeah, chronic osteomyelitis. So any osteomyelitis or septic arthritis can cause.
Yes, sir.
So whenever you tell about a swelling, you just tell about the complaints caused by the swelling also.
Okay, sir.
So it is, since you have already mentioned, it is very close to the knee joint. It is lower under the femur, lower under the thigh. So it will
Yes, sir.
definitely cause some amount of locomotion difficulty, because it is, so that it has to be elaborated in your history.
Yes, sir.
Got it? And next, can you go to the next slide, please? Yeah. So here you can see. So there will be difficulty for him to walk. There should be some amount of pain there. So because of that, there will be over usage of the other limb, and there
Yes,
is
sir.
wastage of the muscles in this limb.
Yes.
Got it? So there will be definitely some difficulty in locomotion. Okay, next slide, please. So in most of the soft tissue sarcomas, they mention about some history of trauma. How do you relate this with this in this case?
Sir, he has trauma 8 months ago, sir. Following trauma, 4 months, 4 months following trauma, he developed a swelling, sir.
Okay.
In few soft tissue sarcomas like rhabdomyosarcoma, trauma is one of the etiological factors, sir.
Okay.
There will be excess inflammatory changes which leads to tumor genesis, sir.
So you mean to say the cricket ball hitting has caused him rhabdomyosarcoma?
No, sir. Probably, sir. One of the reasons, sir. Most common cause is genetic and idiopathic, sir.
So what are the most common causes of sarcomas? Have you ever seen a sarcoma which has happened because of trauma?
No, sir.
So actually, what are the causes of sarcomas?
Idiopathic, sir. Genetic, sir. And exposure to radiation and chemical exposure.
So you know already the cause of the commonest cause of trauma. So
Yes,
never
sir.
tell the causes which are rare or which are undocumented. Okay.
Okay.
So most of the time they will have a history like this. Even in breast swellings also, they will tell there is a antecedent history of trauma.
Yes.
So it is actually the trauma which brings into notice for the patient that there is a swelling there.
Yes, sir.
So that is the issue. So it is like a confounding factor. It's a coincidental event. So never tell trauma as a cause for any kind of sarcoma. So what is the literal meaning of sarcoma?
Sarcoma is a rapid growing tumor arising from the mesenchymal.
So what is sarc? What is oma?
Mesenchymal cell origin.
No, literal meaning, literal meaning. So you have a literal meaning, no? Your name has a literal meaning, right? So
Oma
like
is
that
tumor.
sarcoma, what is sarc? What is oma?
Oma is tumor.
Yeah, oma is tumor, and what is sarc? You see sarcoidosis, sarcopenia. So what is sarc means?
Stop. I don't
Sarc
know.
means flesh.
Flesh, yes.
Flesh. Okay,
Yes.
flesh. So it is a tumor arising from the flesh. So it is not an injury. Okay, literally
Yes,
it means a tumor arising from the flesh. Okay.
Yes, sir.
So it is even though they say an antecedent history, you have to tell it is not the cause, but it is an antecedent history which brings into notice that there is a tumor there. Okay.
Yes, sir.
So next thing, go back to the next slide. Yeah, next slide. Yeah, you have already discussed. And here, no history of neurovascular deficit or neuromuscular deficit. So what are the things you will expect in this case?
Sir, due to as the swelling is rapidly increasing, sir, it might lead to compression of the underneath nerve and vascular
What
structure.
now? What now?
Sciatic nerve.
You
Popliteal.
mentioned it is in the anterior aspect. No, I can see the tumor in the anterior aspect. Where do you get sciatic nerve there?
Posteriorly, sir. Sciatic nerve.
So what nerve I'm asking? What nerve you see in the anterior aspect, in the lower end?
Femoral.
Femoral.
Yes, sir.
So femoral at that point, will it supply any of the muscles there?
Quadriceps femoris, sir.
Yeah, got it. But will at that point, will it supply the muscles at that point, the lower end, or
No,
it will supply in the middle or in the upper end?
Middle and upper, sir.
Middle and upper.
Yes,
Okay. So what other nerves? Any sensory nerve is there? Medial aspect. So medially, what do you have? Some canals is there. No, what is that canal?
Adductor canal, sir.
What is the other name of adductor canal?
Hunterian canal.
Or subsartorial canal. Okay.
Subsartorial, yes.
So what are the structures? Can you elaborate on the structures or contents of the subsartorial canal or Hunterian canal?
Yes, sir. Femoral artery, sir, and obturator nerve, sir.
Is it femoral artery or something else? So can you track the course of femoral artery? Is it anterior, posterior, medial? How it goes?
Anteriorly, sir. Then it pierces adductor longus and goes posteriorly and continues as popliteal artery.
So popliteal artery at the level, the lower end of femur, where it is? Anterior, medial, posterior? It is
Posterior.
posterior, predominantly posterior. Okay.
Yes, sir.
So which artery, if at all it is going to compress, which artery it will compress?
Popliteal artery.
No, the tumor is in the anterior, no?
Yes,
So
sir.
how can it
Femoral artery.
compress?
Femoral artery, sir.
So there is some other femoral artery. What is that called?
Profunda femoris.
Yeah, profunda femoris. So profunda femoris is the main artery in the thigh muscles. Okay.
Yes.
So that's muscle. So if at all the patient is having any pain due to claudication, so where the pains will be?
Distal to the compression, sir.
Yeah, distal to the compression. It will be predominantly in the thigh only, not in the calf muscles. What I
Yes.
mean to say. Got
Yes.
it? Because
Yes.
the calf muscles will be spared. And
Yes.
you mentioned about the neural deficit. So sciatic nerve will not be compressed. So sciatic nerve, where does it come?
Posteriorly, sir. It starts from L4, L5, S1.
Yeah. So posteriorly means this in this kind of tumors, anteromedial tumors, it will be definitely spared. Okay.
Yes, sir.
So what are the branches of this sciatic nerve?
Sir, it divides into common tibial nerve and common peroneal. Tibial nerve and common peroneal.
Common peroneal and tibial nerve. Okay. So it can have a middle bifurcation or lower bifurcation, sometimes a high bifurcation also.
Yes.
Okay. So no history of fever. So what thigh swellings will have fever?
For infective swelling, sir, chronic infective swelling.
Chronic or acute? Anything?
Acute, sir. Sorry, sir. Acute
Yeah,
infective.
acute. And you mentioned about no history of swellings in anywhere of the any part of the body. So why do you want to tell that? Anything positive here?
To rule out neurofibromatosis, sir, as it's associated with multiple swellings throughout the body.
Okay. So everything whenever you tell the history, it should be in order. So last thing you mentioned us about the metastasis.
Yes.
So no history of suggestive of distant metastasis. What type of distant metastasis do you expect here?
Sir, soft tissue sarcomas are usually hematogenous spread, sir, but they have lymphatic spread, and most common site of spread is lung, sir. So to rule out, I ruled out lung by asking in the symptoms. Chest pain.
What symptoms? What symptoms you will ask for lung metastasis?
Chest pain, difficulty in breathing, and cough, sir.
Cough and hemoptysis.
Yes.
Any other signs or symptoms of distant metastasis other than lung mets?
Jaundice, sir. Abdominal distension and jaundice.
Why? Why does it happen?
Liver spread to liver.
So liver spread, is it common in limb sarcoma?
No, sir.
So then why do you want to mention about jaundice? So actually in examination, we will pull you. We will pull you.
Yes, sir.
But you should not come near
Yes, sir.
Near this place, okay?
Yes, sir.
So just because I asked, you should not tell. So what are the metastases you will see in sarcomas? One is lung. What is the next commonest? Next commonest. There are some exceptions in sarcomas. You told about hematogenous spread. What is the other spread?
Lymphatic, sir.
Yeah, lymphatic spread. So what do you expect if there is a lymphatic spread?
Regional lymph nodes, sir.
Yeah, what is the
lymph nodes?
So what regional lymph nodes you expect here?
Inguinal lymph nodes of the ipsilateral limb, sir.
Vertical, horizontal, medial, lateral.
Vertical, sir. Vertical nodes.
Vertical.
Yes.
So
sir.
you expect one thing is the chest symptoms and another thing is swelling in the groin.
Groin, sir.
Or swelling in the inguinal region. So these are the histories you should have asked.
Yes.
So when you are telling that there is a no history, even a negative history is very significant and very important in history taking. Okay.
Yes, sir.
So it determines whether the disease is going to be curable or not.
Yes, sir.
Okay. Next slide. So no
Sir,
comorbidity.
I think, sir, one moment, sir. I think
Yes,
Dr.
sir.
Priyanka has raised her hand. Is that Professor Priyanka, madam?
Hello. Yes, sir.
Madam, if you wish to ask question, please interrupt and ask, ma'am.
Yes, sir. Sir,
Yes,
I
ma'am.
would like to ask to the PG student that how could you differentiate these swelling from that is the course that he mentioned that it's a traumatic and suddenly it's increased in the size. So how do you differentiate that the size of the increase is because of the infective and not a malignant one? On the basis of the history, how do you differentiate it?
Ma'am, on the basis of history, ma'am, the swellings, the patient that
What are
complained
the
us,
positive signs? What are the positive signs that shows that it is an infective swelling? And what are the negative signs that show it is not infective, it is exactly a malignant one?
yes, ma'am. Ma'am, to say it to be a malignant, it started with a swelling and followed by pain. If it has been an impacted, it started with pain followed by swelling.
And any
And,
signs? Any other signs?
and there will be skin changes, ma'am, and local inflammatory signs will be there.
So it is suddenly increasing. So suddenly increasing is something that has been vascular, that may be suddenly increase in the size, like in a hematomatous, something. So that you could see that clinically, is it looking like that it is not a vascular one, it's exactly a benign or malignant in origin. Something
Yes,
soft tissue in origin, it is not vascular. Is it
yes.
looking anything that is clinically?
No, ma'am.
Huh? No?
Ma'am, I didn't get you.
I want to ask that suddenly increasing that is of traumatic origin. It could be the vascular also. There may be
Yes,
the some aneurysm that has been suddenly increasing in the size. It is not a, always malignant one. Hana, so how could you differentiate that it is not a pseudo aneurysm? It is a malignancy only. What are the
pulsatile,
things that have,
pulsatile
huh?
nature. Pulsatile nature, ma'am.
Pulsatility. Yes, pulsatility. The patient will complain that suddenly what thing is happening?
Ma'am. You will have claudication.
Claudications and
There will be discoloration of the limb,
discoloration, cyanosis,
sinuses,
and
yes,
some gangrene, distal gangrene. If it is an
distal ganglion.
exactly
Yes,
compressing engine, है ना? There is
yes,
nothing, any signs of the distal gangrene.
yes,
Okay,
ma'am.
it is it is looking like it is in a cancer only. Huh?
Yes, ma'am.
So, okay, continue. Next slide.
Slide. Next slide, sir.
Professor Ibrahim, sir, you'd like to ask any questions, sir? Or can you go ahead?
Yes, sir. So can you just summarize only the positive findings here, which tells that this is a malignancy?
Sir, swelling
Can
over
mark
the
2-3 points.
sir, swelling has a rapid onset of rapid increase in size, sir, and there
Okay.
is pain associated with the swelling, sir.
No, pain can be there even in inflammatory also.
Yes, sir.
So positive things, you just tell, elaborate.
Recent onset of pain, sir.
Okay.
And the swelling size is more than 10 centimeters, sir.
Okay.
And it's not superficial, sir.
So these are that's our examination. I'm just telling about the history wise. So history wise, you can just elaborate like it's a swelling arising in the thigh, lower end of the thigh,
Lower end of the thigh.
which was painless initially, which has become painful now, and there is rapid increase in size. So these are the points which suggested it can be malignant.
Yes, sir.
Okay. So okay. Now history wise, these are the only positive things you have got as of now.
Yes, sir.
Right. So you can
Yes.
go next to the examination. Yeah.
Going to the examination.
Yeah.
Examine the patient in a well-lit room and adequate exposure after taking an informed consent, sir. Patient is conscious, coherent, cooperative, oriented, and well-built, and is well-nourished. And his ECOG score is 1, and his BMI is 25.4. And vitals pulse rate is 84 per minute, and respiratory rate is 18. And his blood pressure is 130 by 70 mmHg, and he's afrapparel. And there is no evidence of pallor, icterus, cyanosis, clubbing, koilonychia, pedal edema, or generalized lymphadenopathy. And his gait is normal. And local examination, sir.
We'll stop here. Can you just go to the previous slide, please?
Yes.
So you have mentioned about pulse rate, right? Pulse rate.
Yes, sir.
Where did you look for the pulse?
Right upper arm, sir.
So in case of limb tumors, where do you like to see the pulse?
I would like to check distally, sir.
So where you should have looked into actually?
Dorsalis pedis, sir.
Where? Right, left?
Left side dorsalis pedis, sir.
So left side dorsalis pedis is very important. Why it is important?
We'll get to know whether the swelling is compressive and it's like, impacting its on the artery, sir.
So it can impact, or it can compress, or it can enclose it, circulate it completely and cause a compression, right?
Yes, sir.
So what will happen in those instances? Imagine the tumor is completely compressing the artery. Imagine it is completely compressing the
Yes,
popliteal artery. Okay. So what will be there? What will be your findings in the thing in pulse alone, in the dorsalis pedis pulse alone? So when you are looking the dorsalis pedis pulse, what will you see?
Irregular rhythm.
No, this is not medicine. This is surgery.
Yes.
We don't expect arrhythmias here.
Yes, sir.
What is more important? It is the rate and the volume.
Rate and volume.
Volume, okay?
Yes.
So if there is a good amount of significant compression, the volume will be less. Sometimes
Yes,
even the rate may be less.
Yes.
So how you will know the volume is less or the rate is less?
Rate will calculate. So volume will.
How will you quantify the volume? In the dorsalis pedis, how will you compare the volume? In other words, how will you compare the left leg with other structure? Which other structure?
Opposite limb.
Opposite. You have got two limbs, right? So
Yes,
whenever you look for the dorsalis pedis, palpate simultaneously on the contralateral side also.
Yes,
Look
sir.
for the volume. You will see an obvious difference if there is a compression. So
Yes,
the rate can also be assessed, and also the volume also can be assessed.
Yes.
That's the easiest way. So no need to tell about radiofemoral delay and all.
Yes, sir.
Even though radiofemoral delay will be there if there is compression, you can easily compare with the contralateral dorsalis pedis.
Yes.
Okay. So how many percentage of people will not have dorsalis pedis? So if the dorsalis pedis is not there, will you tell it is compression only or something else?
No, sir. I don't know the percentage.
So there are different studies. Up to 2 to 10% of people may not have dorsalis pedis also.
Yes.
So just because it is not there, you cannot tell it is definitely compression. It can give you a clue that it may be a compression. Okay. So this is also another differential diagnosis. There may be an congenitally absent dorsalis pedis artery.
Yes, sir.
So in that case, you can look into the other signs, as you mentioned, the pallor, cyanosis, everything. Okay.
Yes.
Okay. Next slide. Yeah, you can go to the local examination.
Yes, sir. On inspection of bilateral lower limb, sir, there is no limb length discrepancy between the both limbs, and the right lower limb appears to be normal. And on examining the left lower limb, on inspection, a visible single diffuse swelling over the distal left thigh, extending anterior medially to posteriorly. It's ovoid in shape with smooth surface, occupying almost 2/3 circumference of the left thigh, and the skin appears to be shiny and stretched with engorged veins over the surface of the swelling, and there is no muscle wasting and edema distal to the swelling, and there is no visible inguinal swelling. On palpation, there is
Wait. No, wait. We'll go back to inspection. Yeah. So you have mentioned this no limb discrepancy, left limb visible diffuse swelling. That's okay. So you need to mention about scar. Even though the patient mentions
yes,
there is no previous history of scar, previous history of surgery, scar is very important.
Yes,
okay. So you mentioned about cricket ball trauma.
Yes, sir.
Okay. But scar is a proven etiology for sarcomas.
Yes, sir.
Chronic non-healing ulcers, scars will be there. Even
Yes.
though surgery may not produce scar can be produced with some other things like burns or something like that.
Yes.
So scar is very important. So scar history has to be asked, and scar history has to be seen.
Yes.
So that is very important. And you mentioned about engorged veins. So what vein normally will be there in the medial aspect of the thigh?
Medial aspect, great saphenous vein.
Great saphenous vein. So is it the great saphenous vein which you are seeing as engorged, or any other vein is there which is engorged? No, you saw the patient, right?
Yes, sir.
So I'm asking you, you saw only one vein, which is an engorged vertical vein, or it's a network of veins?
Networks.
So how normally in soft tissue sarcomas it will be? So why does the veins get engorged?
Clinical image.
Why does the veins get engorged in a swelling?
Due to expansile nature,
What is expanding?
the swelling and the skin is overlying skin.
So why the skin is shiny?
Due to stretched out, got stretched.
So in a benign swelling and a malignant swelling, what will be the difference in the skin texture or the tension?
In malignant swelling, as there will be rapid increase in the size, the skin gets stretched out.
Exactly. So the rapid increase in size of the tumor causes the skin to be stretched and
Yes.
it is more shiny, and that shows the veins to be more prominent.
Yes, sir.
Got it? So whenever you are putting a venflon, no, you make the limb to be
Compressed.
engorged. So
Yes, sir.
engorged, you do some maneuvers and make the distal part of the limb engorged.
Yes, sir.
So when it gets engorged, the veins will be more easily visible.
Prominent.
And another thing is there will be some amount of neovascularization.
Yes, sir.
And another thing is there might be compression of the deeper veins.
Yes, sir.
So these are the causes why you see a engorged vein over the tumor.
Yes, sir.
Okay. So
Yes,
scar history, scar inspection, in the inspection
Yes,
itself,
sir.
scar has to be told.
Yes, sir.
And are you mentioning about any pulsatility in this thing?
No, sir. I mentioned it in palpation. There is no visible pulse.
No, visible is local inspection.
Yes,
So
sir. Yes, sir.
So it should be mentioned in
Inspection, sir.
inspection and palpation.
Yes, sir.
So if you mention palpable pulsation means it is palpatory finding. Visible
Visible is
pulsation
on
means it's an inspectory finding.
Yes, sir.
So that has to be mentioned because that is very important. Why it is very important?
Pulsatility nature should be ruled out, sir. To rule out
Yeah,
the
why?
origin. To rule out the origin, if it's from vessel, if it's to rule out aneurysm.
So is there any have you ever seen any tumor which is not visibly palpable, is visibly pulsatile, but on palpation it is pulsatile? Have you ever seen such swellings?
No, sir.
Have you seen follicular carcinoma, thyroid?
Yes, sir. Thyroid.
So have you seen any metastasis from follicular carcinoma thyroid?
No, sir.
So renal cell carcinoma and follicular cell carcinoma, they will have expansile metastasis.
Yes, sir.
Because of increased vascularity, those metastases will appear like soft tissue sarcomas.
Yes, sir.
Okay, they will appear as soft tissue sarcomas. And if you do a biopsy in that, you will be in soup.
Yes, sir.
So not vascular swellings alone will be palpable. There are some swellings, metastatic swelling from tumors like RCC and follicular carcinoma, which will mimic like a soft tissue sarcoma, but it will be on palpation, you will see a pulsatile swelling.
Yes, sir.
Okay.
Yes.
So scar and pulsatility very important in soft tissues. Next slide, you can go.
On palpation, sir, all the inspectory findings are confirmed, and there is no local rise of temperature, and a 15 into 22 centimeter non-tender ovoid swelling occupying the anterior medial and posterior compartment of left thigh, and it's extending superiorly 25 centimeter from the pubic tubercle and lower border 32 centimeter from the medial malleolus of left foot. It is firm in consistency with ill-defined margins and is non-mobile, and there are no palpable pulses over the swelling. And
so once again, I'll just stop you here. So
yes.
why do you want to take a 32 centimeter from the medial malleolus? Is there no other bony prominence like tibial tuberosity?
Tibial tuberosity, the swelling was, I couldn't feel the tibial tuberosity, sir.
So you mean to say the swelling has crossed the tibial tuberosity?
No, sir, but the tibial tuberosity was not prominent, so I couldn't take it from the tibial.
Why, he is a 20-year-old guy. Definitely the tuberosity will be there. Even if it is not there, at least you can feel the patella, no?
Yes.
So it's there. We can see the patella on the both sides.
Yes, sir. Actually, the swelling was more on the medial side, sir. So
No, patella is on the anterior side. So it is always
yes,
better to take measurements from the closest bony structures.
Okay, sir. Yes, sir.
Closest bony, not from malleolus or malleolus of other patients. Okay.
Okay, sir.
So this 22, 25 centimeter, 32 centimeter, and so on, it is very difficult to imagine.
Okay, sir.
So if you tell 25 centimeter from the pubic tubercle and 32 centimeter, and you have already told 15 into 22 centimeter, the height is 22 centimeter, right?
Yes, sir. 15, sir.
So it is more of a horizontal tumor, not a vertical tumor.
Yes, sir.
So 15. So 15 plus 25, it is almost 40. And 32 centimeters. So you are taking into account the entire lower limb. So that is not good. Okay.
Okay, sir.
It doesn't come into our imagination at all. Okay.
Yes, sir.
So it's better you tell about the knee joints instead of
Okay.
telling about the other areas. Okay. Yeah.
Okay.
Next.
Sir, one second, sir. I think
Yeah.
Professor Priyanka,
Yeah,
ma'am.
madam.
Yes.
Madam wants to ask something. Yeah.
Yes, sir.
Yes.
Yes, ma'am.
On the basis of the history and examination that you are going to be in the inspection, in the palpation, locally examined, are you able to make the census that what in which way you have to proceed to your patient? That is it a really an acute emergency? It is in a salvageable limb. It is not a salvageable limb, or you need to go for some sophisticated investigations for its further management. Are you able to make your mind over that on the basis of the history and the clinical examination? Is it looking like an acute emergency?
No, ma'am.
No, ma'am. So what does it look like? That you have to go for the higher investigations?
Ma'am,
What higher investigation you would think about?
ma'am, after to confirm my clinical diagnosis, ma'am, I would go ahead with investigating the patient with MRI, ma'am. MRI of the left knee.
MRI of the left knee. And what are you thinking about that you have to go for any type that's a simple excision or any type of the biopsy you want to go for, or some any other team that you need to for the further evaluation? What other team? Are
Ma'am,
you able to
on MRI, I would get to know that the exact size of the tumor, shape of the tumor, and its relation with the surrounding structures, ma'am. Then to get
it
the
is a
grade of the disease and to stage the disease, I
uh,
would like to go ahead with core needle
it is
biopsy.
a huge swelling. It is a huge swelling that is clinically obvious. Okay, and
Yes.
he is not having any type of the locomotory difficulties. He is not having difficulty in walking. He is not having any vascular sign. He is not having any bony, at least, and no any signs of the systemic metastasis. So I think on these basis you will be able to you will be able to excise this or not. What do you think for?
Ma'am, I did not get you.
I'm saying that this is exactly a tumor that needs more sophisticated investigation. Are you able to manage it? That local excision or biopsy?
Ma'am, I would first go ahead with USG guided core needle biopsy, ma'am.
Okay, then you will be able to manage it.
Yes, ma'am. I would like to, after getting core needle biopsy, I would like to, I would be able to get the grade of the disease, and I would like to stage the disease, ma'am. Then after staging the disease, I would like to go ahead with further management.
So next slide, would you show me the next slide, inspection, palpation, and then?
Neurovascular.
So there is no neurovascular problem. Deep reflexes all preserved. Bilateral, all arteries are all normal. Then next slide.
clinical image,
Next slide.
systemic
Systemic
examination,
examination. No problem. Then come to the next slide.
summary of, yes.
What is the summary next? Could you say in the 2 lines?
Ma'am, 20-year male, ma'am. Large
Ah.
first non-mobile swelling over the anterior medial and posterior aspect of left distal thigh of 4-month duration, and which is associated with rapid increase in size and pain since last 10 days, with no clinical neurovascular involvement. And with that summary, I would like to come to a diagnosis of uh, soft tissue tumor, probably malignant, of the left distal thigh.
Okay, and how would you make it that soft tissue tumor? Have you go for the biopsy?
Ma'am, yes, ma'am.
What is the biopsy?
We
What
have
was the
done,
biopsy? Needle biopsy. This is the histopathology. What
yes,
is the
ma'am. True
needle
cut
biopsy?
biopsy, ma'am. True cut biopsy. We have
What
coordinated.
is the true cut biopsy report?
It was showing multiple linear cores of spindle cells, ma'am, with moderate pleomorphism and occasional necrosis, and impression was spindle cell tumor, ma'am. And for
Spindle cell.
the further we have done immunohistomarkers, ma'am. Desmin was positive. There was IKI67 index, and it was suggestive of rhabdomyosarcoma.
So what was your plan of treatment?
Ma'am, after
What
getting,
are the findings of the MRI? What are the findings of MRI?
ma'am, MRI, it was a heterogeneous hyperintense lesion on T2, ma'am, which was arising from intermuscular plane of posterior compartment, and it's measuring 12 into 9 into 9 centimeter, and it's in close proximity with sciatic nerve, and
It is really encroaching the sciatic nerve or not?
no, ma'am, clinically no, ma'am.
So from where its origin?
It's originating in the intermuscular plane of posterior compartment of distal thigh.
So what is it? Is a skeletal muscle tumor exactly?
Yes, ma'am.
Skeletal muscle tumor. Okay. So which muscle is it arising in between the muscles? Hello?
Yes, ma'am. Ma'am, posterior compartment,
Intermuscular. Intermuscular
intermuscular.
muscle.
Yes, ma'am.
Okay. Next slide. So what you plan for that? What surgery you will need for this?
Ma'am, after getting to the diagnosis of rhabdomyosarcoma on biopsy, ma'am, I would like to put the case in tumor decision board, ma'am, multidisciplinary team. Then,
Yeah,
which includes surgical oncologist, radiation oncologist, medical oncologist. Then I would like
very
to
good.
go ahead with further treatment, ma'am. I would like to rule out metastasis by getting a CT chest done, ma'am.
PET CT, or you can go ahead with the PET CT to know any bony or distant metastasis.
Yes,
Now, what you yeah. Next, your plan for that surgery. What surgery you will advise for this patient? If it
ma'am.
is in PET CT, it won't be
Ma'am,
malignant.
as it is a rhabdomyosarcoma and the tumor is more than 10 centimeter in size, we would like to go
Huh.
ahead with neoadjuvant chemotherapy.
But it's very painful. It is 10 days. It's excruciating painful. The neoadjuvant therapy is able to subside some pain.
Ma'am,
Neoadjuvant, it is a very painful now. For the 10 days, it is increasing pain. So what you will plan for management?
so you are asking about surgery, ma'am.
Yes.
Ma'am, I would like to go ahead with wide excision, ma'am. Wide excision of tumor.
And then
Wide excision of tumor followed by, based on the post-operative histology, margin status, and pathological diagnosis, I would like to go ahead with post-operative radiotherapy.
yes, post-operative radiotherapy and chemotherapy.
Yes,
Any other slides you would like to discuss?
ma'am. I didn't get you.
Any other slides you would like to discuss?
Slides, ma'am.
Yes.
No, ma'am. This true cut biopsy. That's it.
Okay.
Actually, the patient is pre-op patient, ma'am. Right now, he came like 20 days back, ma'am. So we have
Okay.
advised him to undergo. We have referred him to radiation oncologist, ma'am. So
Okay.
they have referred to medical oncologist. So they have advised for neoadjuvant chemotherapy, ma'am. The patient is presently on
Okay.
heme therapy, ma'am.
Okay. Okay. Patient is in a new adjuvant chemotherapy.
Yes, ma'am. Right, ma'am.
Okay. Would you like to give some pain management for this patient? He is very painful.
Yes,
For 10 days. What
analgesics.
pain management?
I'll give her. I'll go ahead with analgesics.
Analgesics except that patient controlled analgesia.
Yes,
You
ma'am.
can give patient controlled analgesia because he is very painful. Okay.
Yes,
You can ask the patient for some epidural.
yes,
Okay.
ma'am.
For the because this is a big tumor. Let me call and causing the compression over the sciatic nerve. So before
Yes, ma'am.
going for the this is the radiotherapy, you have to give some painkillers or pain relieving medications therapy for relieving of the pain so that the pain will be relieved. Then you have to advise the patient what the oncology board has been advised to you.
Yes,
Okay.
yes.
Yes. Thank you.
Thank you.
Thank you.
Professor Ibrahim, sir.
Yeah, yes, sir. So Narayanan,
Sir,
so you mentioned about in the diagnosis, it is a soft tissue sarcoma, right?
yes, sir.
So I just wanted to know, how did you exclude that it is not a bony sarcoma with soft tissue extension with clinical examination alone?
Sir, bony based on history, bony swellings are starts with pain and followed by swelling, sir. So
Not
by
always. Not always.
yes, sir. Clinically,
Most of the time, bony swellings also will start without pain only,
yes,
and
sir.
after it is becoming bigger and bigger, it will produce pain.
Yes, sir.
Okay, so it will have the same history.
Yes, sir.
So can you tell it as a bony swelling with soft tissue component? What are the points for and points against?
Consistency, sir. Bony swellings
Okay.
are hard in consistency.
Yeah, you are not going to palpate the bone directly. So
Yes,
bony
sir.
tumors, when it expands and has soft tissue component, it will have the same consistency like muscles only.
Yes, sir.
So in the final diagnosis, you should mention it is a tumor arising from the lower end of femur. So first differential diagnosis is the soft tissue sarcoma.
Yes, sir.
So second diagnosis or a second differential diagnosis is the bony tumor,
Having a
okay,
soft tissue.
with the soft tissue component. So why
Yes,
it is
sir.
very important is, so you don't see soft tissue sarcomas in this age, 20 years. But
Yes,
to
sir.
see a osteosarcoma, what is the most
Osteosarcoma.
commonest site of osteosarcoma?
Long bone, sir, and it arises from diaphysis.
No, actually, you are an MS postgraduate, okay?
Yes,
So you should not answer like an MBBS surgery student.
yes, sir.
You should be more
Diaphysis
specific.
of femur.
What is the
Distal,
most commonest site of osteosarcoma in our human body?
humerus, sir.
Have you ever seen a
Large.
soft tissue sarcoma? Have you ever seen a soft tissue sarcoma?
No, sir.
No.
Soft tissue, sir. Osteos.
Or osteosarcoma?
No, sir.
Osteosarcoma, have you ever seen bony sarcomas? No.
No,
So
sir.
most commonest site of osteosarcoma, that is bone sarcoma, it is the lower end of femur.
Yes,
So you are
sir.
mentioning in that age group also, 20 years, lower end of
Yes,
femur. So first thing which will come into any clinician's mind is a bony tumor, osteosarcoma,
yes, sir.
because the metaphysis would have not completely disappeared. Okay.
Yes,
So
sir.
second most commonest is the upper end of tibia.
Yes, sir.
Okay. So in the differential diagnosis itself, you should mention that this is the thing. Okay. What is the
Yes,
thing?
sir.
It is a differential diagnosis. First is
Differential
the soft
diagnosis.
tissue sarcoma. Second, it can be a bone sarcoma.
Bone,
Okay.
bony. Yes, sir.
So you mentioned about something called MRI. So before that, would you like to take any other basic investigation?
Sir, to rule out bony involvement, I would like to go ahead with X-ray.
X-ray. So
X-ray of
X-ray local parts, thigh
X-ray
with.
of the X-ray of the left knee, sir.
So what are the information you will get in the X-ray?
Sir, X-ray, if it's arising from the bone, sir, there will be breach or discontinuity in the bony.
Okay. And also, what about the joint?
Joints.
What will you look in the joint? Actually, when we are discussing about the palpation, I wanted to tell you that examination of the nearby joints also. So you
Yes,
mentioned that the movements are good, the gait is
Yes, sir.
normal, but you should mention about the nearest joint. The nearest joint is the knee joint.
Knee
So you
joint.
look for any parapatellar fullness,
Yes,
any effusion, joint effusion. So that
Yes,
can
sir.
come. Even in a soft tissue sarcoma, there are some soft tissue sarcomas which can produce skip metastasis across joint.
Okay, sir.
Like synovial cell sarcomas can produce thing, even though it is not a bony tumor.
Yes,
Soft
sir.
tissue synovial cell sarcomas can produce skip metastasis across joints.
Okay.
Okay. So the examination of the nearest joint is mandatory. So that has to be
Yes.
mentioned in subbedding. And other thing is coming back to the thing. So the X-ray, you see the tumor, origin of the tumor, any architectural distortion of the bone.
Bone.
Next thing is any in the soft tissue, any calcification is there.
Yes, sir.
Okay. Next, see for any effusions in the knee joint.
Fine.
Okay. So these are all the things you see in the X-ray. So
Yes,
X-ray itself will give you a clue whether it is a soft tissue sarcoma or a bone tumor
Bony
with some
tumor.
component.
Yes,
Okay.
sir.
So next thing you can go. What is the next investigation you would like to do?
After radiological investigation, sir.
No. What is it? You have taken X-ray. What
X-ray,
is it?
X-ray, sir. I've done X-ray, sir. Then
Next.
I ruled out it's bone. It's not origin from bone, sir. Then I would like to go ahead with MRI of left knee, sir.
Yeah. Again, you are telling it's a left knee. You wanted to take MRI of the left knee. You want to see
No,
the
sir.
anterior cruciate ligament, ACL, PCL,
No, sir.
medial
Left.
meniscus, collateral ligaments,
No, sir. Left lower limb.
left lower limb.
Left
Which
thigh.
part? Be
Left
specific.
thigh. Left thighs.
Left thigh, including the knee joint.
Yes, sir.
Okay, you should be more specific. So the MRA should cover the entire. So if you write in the prescription that MRA left knee, they will produce a left knee thing. ACL normal, PCL normal, meniscus normal, collateral ligaments normal. Then the patient will think it is normal and he will go home. So you surgeon only is going to order the investigation. Okay. So the order of why do you want to investigate in this patient? Why do you want to investigate the patient? You have seen the tumor. You can directly go and operate directly. Why do you want to investigate? What is the indication or target of any investigation?
Sir, to confirm the clinical diagnosis, sir, and to
Okay.
get to know about the tumor shape, size, and its relation to the surrounding structures, sir.
Okay.
And the
Just,
flame.
okay. So just important thing to investigate in a tumor is only two. One is to confirm the diagnosis. Okay.
Yes, sir.
Next is the metastatic workup.
Yes, sir.
So these are the two things. So confirmation of diagnosis mostly by histology only.
Histological.
Okay. And
Yes,
next thing is the metastatic workup. So metastatic workup includes both local and distant. So
Yes,
local workup, metastatic workup shows the extent of the disease.
Yes, sir.
And distant metastatic workup shows the metastatic nature of the disease.
Metastatic to the other.
So before doing metastatic workup, it is normal to do a confirmation of diagnosis.
Yes,
so
sir.
why you are not confirming the diagnosis and why you want to do the MRI first?
Sir, as biopsy, if we do earlier biopsy, it might lead to anatomical distortion, sir. So later MRI would be due to biopsy the needle site, there might be distortions, anatomical distortion.
So one thing is there will be distortion of the anatomical structures.
Yes, sir.
And number two is we don't know where to put the needle.
Yes, sir.
Okay. There
Yes.
might be some vascular structures, neural structures underneath.
Yes, sir.
And also we don't know whether the tumor is single, multiple. Okay.
Yes, sir.
Okay. So that also we cannot say.
Yes, sir.
And another thing is it is always non-invasive, precise, invasive.
Non-invasive followed by invasive.
So MRI, you have done MRI, lower thigh region. So what are the things you will see in the MRI? So you got very good images. It's a 1.5 Tesla or a 3 Tesla?
1.5.
1.5. Very good imaging and very good reconstructions they have given. Coronal cuts and all, coronal and
Okay,
sagittal cuts are excellent. It looks well operable also. Yeah. So what are the things you will see in the MRI?
I'd like to see the size
No,
of
that
it.
like to. There is no like to.
Yes, sir. I would see.
You will see. Yeah.
Yes,
There is no like and all here. In surgery, it is the protocols which
Yes, sir.
determines. It is not your likes or my likes or your dislikes or my dislikes. Okay. So tell I will.
Yes.
Yeah. Tell me.
I will see the tumor size, sir.
Hmm.
And, its relation with the nearby structure, sir.
Hmm.
And its plane of origin, sir.
Hmm.
And its extent, sir.
Hmm.
And
Whether it is operable or inoperable. So that is the
inoperable
most
or
important thing.
Yes, sir.
So that is the most important thing. So what are the signs of inoperability in a tumor in this place?
Sir, when it's infiltrating nearby neurovascular structure, sir.
Hmm. So what are the neurovascular structures it will infiltrate here? So if it is infiltrating the profunda femoris artery,
Yes, sir.
it's operable or not operable?
It's operable, sir, after giving preoperative chemo radiotherapy, sir.
No. I am leave the pre-operative radiotherapy chemotherapy. So you are doing an MRI.
Yes,
Profunda femoris artery is involved. It is compressed or it is 360-degree encircled by the tumor. Is operable or not?
No, sir.
Why? So what are the arteries in the thigh? What are the two arteries in the thigh?
Femoral artery and profunda femoral.
So femoral artery is there, no? So why you are worried about profunda femoris? So which is the artery? Which is the artery which supplies the leg muscles?
Femoral artery and profunda femoris. Leg muscles, sir. Popliteal.
So which artery continues as popliteal artery?
Femoral artery.
Femoral artery. So if the femoral artery can be salvageable, involvement of deep femoral artery alone is not a contraindication for surgery. Okay.
Okay, sir.
So if there is involvement of a sciatic nerve, so it is operable or inoperable. Involvement means it can be abutting, it can be circumferentially encircling 360 degrees. So it is operable or inoperable?
Operable.
Operable. So if the nerve is just abutting, the nerve is stretched, or nerve is just over the tumor, you can still operate.
Yes.
Okay. So the most important sign of inoperability is involvement of the neurovascular structures, mainly the popliteal vessels. Okay.
Yes.
And another thing is, if there is huge ulceration in the skin, if you are not able to provide a skin cover post excision.
Yes, sir.
Okay, so you mentioned the skin is pinchable. So skin is pinchable means there is no skin involvement.
Skin involvement.
Okay. So now MRI has been done. The tumor appears to be operable. Next, what is the next step?
Sir, I would like to confirm the diagnosis, sir. I would like
You
to
again
go.
like you again
Sir,
like
sorry, sir. I would.
You like so many people.
No, sir. I would confirm the diagnosis, sir, by doing core needle biopsy, sir.
So you want to order any other radiological investigations before doing the biopsy?
USG guided USG guided biopsy.
Why do you want to do a USG guided? You already have an MRI picture, limb is palpable, you have the needle in your hand.
Yes, sir. To see the nearest
it is operable.
Yes, sir.
It is operable.
USG imaging guided, we do to take the biopsy specimen from the solid area, sir.
Okay,
rather than the necrotic area.
So you are not confirmed whether it is necrotic or solid areas. Okay, so you can use the USG guided probe. Okay.
Yes, sir.
And I am asking about any other radiological investigation you want to do, like MRI, CT scan. Any CT scan you want to do?
Sir, CT chest, sir, to
why?
static workup. to rule out.
So what are the things you will see in the CT chest?
Like to see lung parenchyma, sir.
So what type of metastasis you see in soft tissue sarcomas? Lung metastasis, effusion, lung mets,
Effusion.
mets, or what type of metastasis you see?
Effusion.
Effusion. So what was the history you mentioned? No, what was the history? There was some history of trauma. No, what is the trauma history? There was a history of trauma in this patient. No.
Yes, sir.
What is the trauma?
It was hit by cricket ball, sir.
Cricket ball. So have you seen cannonball?
Yes, sir. Cannonball.
It will be bigger than cricket ball. So cannonball.
Yes,
so what is
cannonball
cannonball?
metastasis.
Yeah, cannonball secondaries. So that is common
Yes,
in
soft
common in
tissue
sarcomas, not
sarcoma.
effusion. Okay.
Yes, sir.
Effusions are common in carcinomas.
Carcinomas. Yes.
Okay, not in sarcomas. Okay.
Yes, sir.
So sarcoma. Why? Why? What is the reason why this cannonball secondaries are common in sarcomas? Because it is basically hematogenous.
Hematogenous.
Effusions. Why does effusion happen? Because of lymphatic blocks. Lymphatic blocks. Okay.
Yes.
So here there is no lymphatic blocks. It happens because of
Hematogenous, sir.
hematogenous. So hematogenous. Yes. Blood in the lungs. Where will be the blood vessels? Along the pleura or inside the parenchyma?
Inside the parenchyma.
Yeah. So anatomy is more important in surgery. Okay. Every minute anatomy is very important. Yes. So sarcomas. So sarcomas is there. Why it is producing cannonball? Why not oval shape? Or why not cuboid, trapezoid shape? Why it is producing cannonball secondaries? So if you see the tumor in the thigh, you saw the tumor in the thigh, right? Yes, you mentioned it as 15 into 22. That means it's not a regular circle. It's not a regular sphere, right?
Yes, sir.
So how come such an irregular tumor can produce regular spherical balls?
Alveolar.
Because there is the uniform resistance in the lung parenchyma.
Okay, sir.
Okay, lung parenchyma has uniform resistance. The cells grow in all the directions, all the 360 degrees. It grows in a uniform way, and that's why it produces cannonball sarcoma. Got it?
Yes, sir.
But in other areas, like if you are looking into some pleural effusion, there might be some loculations. Some areas will be blocked, some areas will not be blocked. Okay, so that's the reason. Okay.
Yes.
So before doing the biopsy, you do a CT chest. So you don't want to send the patient to radiologist again and again. So you order MRI local path and CT chest.
CT chest.
The disease. Stage of the disease.
Sir, stage of the disease, stage 2, sir.
No. Tell it in TNM.
TNM, sir. T2B, N0,
You
N0.
want to see the slide always, huh? Okay,
no,
tell me.
As the tumor is more than 10 centimeters, sir, it is a stage, the T staging is T3, sir.
And, but you mentioned as T2B?
T2B, sir.
T2B or T3? Tell me properly.
T3, sir.
Okay.
And there is no lymph nodal involvement, N0, and there is no metastasis, sir. So M0, sir. And on histopath, the grading is high grade, sir. So
wait. We are not in biopsy. We have not even done the biopsy now, as of now.
Okay, sir.
Okay, don't go to the grade. So you mentioned about inguinal nodes. You didn't mention about what is the other group of nodes near that area? The tumor is there, no?
Yes.
So what is the nearest lymph node? Is it inguinal or something else? What is where do you find the lymph nodes normally? Along the nerve, along the artery, along the vein?
Along the veins.
Along the vein. So what is the nearest vein to the tumor now?
Great.
Nearest big vein. Nearest big vein.
Great saphenous.
No, I'm telling nearest big vein.
Popliteal.
Nearest popliteal vein.
Yes.
So do you know there are some nodes along the popliteal area?
Popliteal lymph nodes. Yes, sir.
So popliteal lymph nodes also has to be mentioned. Okay.
Yes, sir.
Okay. So what is mean by Hess test? What is mean by Hess test? Hess test.
Test.
Have you ever heard it?
Yes, sir.
Tell me. Somewhere you remember, somewhere in Hutchison. So Hess test we do to know the direction of flow, blood flow in the superficial veins.
Yes, sir.
So is it important here in this patient? Clinically, during the clinical examination, you mentioned about engorged veins. In the picture itself, I can see a engorged GSV, great saphenous vein, I can see it.
Yes.
So, do you like to do a Hess test here? Is it important?
To see the pattern of drainage.
So, you will know whether the flow is from
below
down to up or up to down.
Up to down. Yes, sir.
Okay, so that can be done with a Hess test. You can do with just 2 fingers. You know how to do it, right? You know how to do it.
Yes, sir.
From where it is rapidly filling.
Yes, sir.
Okay, so that has to be mentioned in the palpation. So the direction of flow in superficial veins. So if the direction is reversed, it may show that there may be some deep vein compression or deep vein thrombosis can be there. Got it?
Yes, sir. Yes, sir.
That has to be mentioned. Okay. Now the needle is there. Who is going to do the true cut biopsy?
True cut biopsy.
Or core needle biopsy? Who is the best person to do the biopsy? Radiologist, radiotherapist, medical oncologist, surgical oncologist, general surgeon. So many people are pathologists. So many people are there. Who you are going to give this opportunity?
Surgeons.
Why?
Because he's the one who is going to operate, sir.
Exactly. So the biopsy has to be done by the person who is going to do the final surgery.
Yes, sir.
Why it is more important?
As the plane shouldn't be distorted, sir. And
not only that, the biopsy has to be done away from the neurovascular bundle, number one.
Yes, sir.
And number two is it should be done in the point which will be included in the line of resection. So when you're going to do a resection, right? So you have to include, you have to include that. So there will be some people who will do a cosmetic biopsy. The biopsy, they will think that biopsy scar should not be seen. So they'll do from some backside, lateral, like that. It should not be done. It should be placed in a proper place, location, which should be included in the incision.
Final resection.
Anyhow, the main treatment is surgery only for sarcoma. All sarcoma surgery only. So the surgical incision should include the biopsy scar. Okay, and also it is better to document. There are sometimes the scar may disappear. So tattooing can be done or you can document it. Now everybody is having a mobile phone. You can document it where it has been done so that it will be easy. Even if the same surgeon, you are doing some neoadjuvant chemotherapy, the surgeon may forget it. Okay. So it's better to document where you have done. Okay. So now true cut biopsy has been done. So what are the things you will see in the biopsy?
Sir, on the biopsy.
Have you ever done a biopsy, core needle biopsy? Have you ever done?
Yes, sir. Not for soft tissue, sir. For breast shaft.
Okay, what gauge? What is the
16 gauge needle?
16 gauge. So for this patient, what gauge you would like to use?
14 gauge or 16 gauge?
Which is bigger, 14 or 16?
14, sir.
14. Why do you want to use a 14?
As the tumor is big.
Okay. So you'll get good amount of
to get more amount of tissue, sir.
More amount of tissue.
Later on, we can give it for IHC and cytogenetic studies.
Exactly. So good core, it is better. So you take at least 8 to 10 cores.
Yes, sir. 8 to 10.
Okay, 8 to 10 cores.
Yes.
So how will you know that you have taken the tissue only and not fat?
The tissue sinks in, sir. Fat floats on.
So you send in what material you will send to the pathologist? Saline, normal saline, distilled water,
Formalin.
formalin. Which one you give? Which
Formalin.
confirmed?
Yes, sir.
Or what is the percentage?
5%. 10.
Diluted, undiluted? It's 10% formaldehyde, undiluted.
10%. 10%.
10%, at least 8 to 10 cores. And it, as you told, it will sink. It will not float. If it is floating, means you have taken from fat. You already mentioned in the MRI that it is in the intermuscular plane. So what will be the normal content of the intermuscular plane?
Sir,
What will be the normal content in an intermuscular plane?
content.
Content. What will be there in intermuscular plane? Between muscles, no? What will be there normally in a normal human being?
Adipose tissue, sir.
Yeah, what is that? It is fat.
Fat.
So there is high chance that you may sample fat.
Yes, sir.
Got it? So what are the muscles there in that region? Posterior thigh, you told, no? What are the muscles you will encounter?
Semi-tendinosus, semi-membranosus,
Mm.
biceps femoris, long head and short. Biceps femoris and adductor magnus, part of adductor magnus.
Mm. So what are these muscles grouped called as? These muscle group, you mentioned
Hamstrings.
hamstrings. So you also mentioned about the anterior part, right?
Yes, sir.
It is actually anteromedial extending to posterior.
Posteriorly.
So what are the muscle groups you expect in the anteromedial aspect?
Anteromedial, sir. Anterior compartment includes rectus, quadriceps femoris, and vastus intermedialis, vastus lateralis, vastus medialis. Whereas medially, adductor longus, adductor brevis, adductor magnus, and sartorius.
Sartorius. So almost all the muscles will be covered in this area.
Yes. Yes.
So any muscle can go for resection.
Resection. Yes.
Okay. So anterior compartment, medial compartment, posterior compartment, all compartments. It is almost including all the 3 compartments. Okay.
Yes.
So now in your patient, after the MDT discussion, they were told to give neoadjuvant chemotherapy. What was the indication for in this patient? It is only the size, but
Sir, and it's a high grade tumor, sir.
seeing the MRI, it looks operable.
And it's a high grade tumor, sir, pathologically.
So you want to give neoadjuvant chemotherapy. So what
And
are the
it's
disadvantages?
Sir,
So what are the disadvantages of giving neoadjuvant chemotherapy in an operable tumor?
neovascularization, fibrosis, sir.
No. We don't know whether the tumor is chemosensitive or not.
Oh, yes, sir. Response.
So normally, you know, RECIST criteria?
Resist. Yes.
What is that? RECIST.
Sir, we see pathological response, sir.
Yeah.
PCR.
What can you expand RECIST? RECIST?
It's not like.
Okay, you read about RECIST criteria. Okay. So it can be completely responding, complete response, CR, or partial response, PR,
PCR. Yes, sir.
or stable disease, SD, or progressive disease, PD. Okay.
Yes, sir.
So in sarcomas, we don't know whether it is chemosensitive or not. There might be in some places where the tumor will grow, progressive disease. So it may become inoperable also.
Yes, sir.
So in that case, instead of wide excision, we may have to do a amputation later. So that risk should also be explained to the patient when we are taking him or her for the chemotherapy, neoadjuvant chemotherapy.
Yes, sir.
And in most of the cases of soft tissue sarcomas, if there are no absolute contraindications of inoperability, like vascular encasement or bony involvement or neurological involvement, it is better to go with a wide local.
Sparing. Yes, sir. Limb sparing,
wide local. Imagine you are going to do the surgery for this patient. So what will be the anesthesia?
General anesthesia.
General, but it is in the limb only, no? Why do you want to give general? Block, huh? You want to do in block?
No, sir.
Femoral block?
No, sir.
What anesthesia I would like to give? Have you done amputations? Have you done amputations, diabetic?
Yes,
foot?
sir. Amputation, sir.
How many amputations you would have done? You're in second year, right?
Yes, sir.
How many BK amputations you would have done?
2, sir.
Only 2.
Yes.
You are from Hyderabad. All are very diabetically controlled. You're from Hyderabad, right?
Yes, sir. Hyderabad.
So no diabetes patients, no diabetic foot. So only 2 amputations for a second year PG. Have you ever done a revision amputation?
I have assisted, sir.
Assisted, okay. So what anesthesia normally you give for amputation?
Spinal, sir. Spinal.
Spinal. It's okay. So what anesthesia would like to give for this patient? Ma'am mentioned about some anesthesia, no? Patient is having pain and all. What would you like to give? Ma'am mentioned about something.
Spinal anesthesia.
No, ma'am did not mention about spinal. She mentioned something different. She mentioned about epidural.
Epidural.
Epidural
Patient
anesthesia.
controlled analgesia.
Epidural analgesia. So, in such cases of soft tissue sarcomas of limb, it is better to give combined epidural with the spinal.
Spine.
You know what is advantage?
Post-operative pain. And
One thing is post-operative pain. You can continue the analgesia. Another thing is it will decongest the tumor. Decongest the tumor. Okay, the congestion will not be there much. So blood loss will be less, and also closure will be easy. Closure of the tumor size will be easy because you'll be removing some part of the skin also. Closure will be easy. So always better to give a epidural with spinal. Epidural with spinal. Okay. So epidural with spinal you are giving. So where will you place the incision?
Sir, vertical incision, sir.
Very good. So posteriorly, anteriorly, medially, where you would like to place it?
As the tumor is arising from posterior compartment, I would like to place the incision over the posterior.
But actually in the inspection you told it is anteromedial and posterior.
Extended.
But in the MRI, if I see it's predominantly posterior.
Yes, sir.
So I think the incision may be in the posteromedial or posterior aspect.
Yes.
So what is the most important thing you should mention when I ask about incision in sarcomas?
I did not understand.
No, when I ask about incision in sarcomas, what is the most important thing you should tell here? We discussed just now before. You should include what? Include what scar?
Previous scar. Biopsy scar.
Biopsy scar has to be included. Okay. Okay. Are you able to hear me?
Yes, sir. Yes, sir.
Yeah. So that has to be included. And what amount of margin you want to give?
Sir, 2 centimeter margin all around the tumor, sir.
Yeah, 3-dimensional 2 centimeter margin.
Yes, sir.
Okay. Imagine the tumor is sitting on the periosteum. Even though the MRI mentions it as intramuscular, in a particular spot it is sitting over the periosteum. What you will do?
Sir, I would like to include the periosteum also, sir, while resecting.
So if you include periosteum alone, the 2 centimeter margin will not be there. 2 centimeter will not be there. Periosteum is not 2 centimeter thickness. So what you will do?
Post-operative radio.
No, it's not like that. I'm asking during the surgery. You would like to extra remove the bone also, or you want to do an amputation?
No, sir, not amputation.
Are you convinced in removing only the periosteum?
Periosteum, and I would like to.
Extra bone? Huh?
No, sir.
Then what? There is nothing else. Periosteum, bone, that's all is there.
Yes, sir.
Either you have to remove the bone or you have to do an amputation.
I would like to remove the periosteum, sir.
Yeah, you have removed the periosteum, man.
Yes, sir.
So what extra you would like to do? Nothing is need to be done. Okay.
Yes, sir.
You need not
post-operatively,
based
on the margins.
Not post-operatively. So the teaching is if there is a fascia.
Sir?
Okay. If there is a fascia,
Fascia, yes, sir. We
Deep
should
fascia.
include the fascia also, sir.
If you include the fascia, it is equivalent to giving a 2 centimeter
Giving
margin.
it to some, yes, sir.
Got it? Now you understood?
Yes, sir.
So this is the most important component. Just because the tumor is sitting over the bone, you need not do amputation.
Bone.
You did not remove part of the bone.
Yes,
Okay?
sir.
That periosteum has to be removed in toto without any disruption in the periosteum.
Yes, sir.
Got it? So
Yes, sir.
periosteum, if you remove, it is equivalent to giving 2 centimeter margin. Okay?
Yes, sir.
So you remove the margin, and then what you are going to do? Why? So patient is there, specimen is there. What you are going to do with the specimen? What you are going to do with the patient?
I would like to mark the specimen, sir. Margin.
How will you mark? How will you mark?
Short superior, long lateral.
Okay, so that's your thing. So you are marking, and next thing to the patient, what you are going to do? It's open.
Yes.
There are bleeding spots everywhere. What are you going to do?
Secure hemostasis, sir.
Then
clip the tumor bed, sir.
Yes, very good. Why do you want to clip it?
Because post-operatively, if we are going ahead with radiotherapy, we can see the.
Definitely, such a big tumor will receive radiotherapy.
Yes,
so
sir.
we need to mark, because once you close it, we don't know, the radiotherapist or the radiation oncologist will not know where the tumor was initially.
Yes.
So you mark the margins, or if there is particular margin which is deep like periosteum, you mark in those areas.
Yes.
Okay. So next you close it. Want to close it vertically, horizontally, obliquely?
Vertically.
Vertically. So anything else you want to keep? Such a big cavity?
Drain
Very
close to the incision site.
Yeah, drain close to the
incision site. Close to the incision.
And also along the incision site, just close to the incision. Why?
Along the incision.
Why?
Drain site also post-operative
radiation, one thing. And if there is a recurrence in future, are you there?
Recurrence, sir.
Recurrence. If there is a recurrence, we may have to do a re-excision or divide excision. So then we have to include the drain site also.
Yes.
So it will be difficult to salvage skin at that time. So we do this methodology. Okay?
Yes, sir.
Okay, next what is the next step?
Sir.
What you're going to do to the patient? So suturing, right?
Sure, I would like to
suturing.
Suture.
Drain kept. Next you have to suture, right?
Yes, sir. Suture.
So suture, what suture you would like to use? What suture material you will use? Ethylon. Very good. So monofilament, it will have good tensile strength. So in
for the skin.
So what will be the sutures? What will be the sutures used? You want to use simple mattress, horizontal mattress, vertical mattress? Which one you want to do?
Vertical mattress.
Okay. Vertical mattress. The most important thing here is never take bites well away from the scar. The bite should be close to the scar. That is very, very important. Very, very important. Because if you take well away, the purpose of putting a linear scar will go. The scar will become thicker. If at all we need to re-excise, we have to excise a very big scar. Okay. So these are all the practical things which we face when there is a recurrence. Okay. So you have to take the thing close to the incision.
Yes.
If it's a very small tumor, you can even put a subcuticular also. Such big tumors, you cannot put subcuticular. You either use a skin staples or you take a mattress, the vertical mattress, but the bite should not be very far away. Got it?
Yes, sir.
Okay.
Yes.
So next post-operative histopathology comes. What you would like to do for this patient?
Sir, based on the histopathological report.
Any adjuvant you would like to have? Adjuvant treatment?
Radiotherapy.
Radiotherapy will be there. For such a big tumor, radiotherapy will be there to prevent recurrence. Okay.
Yes, sir.
So is there any role of FNAC in soft tissue sarcomas? You have not mentioned about FNAC at all. Such a big tumor, you would have taken an FNAC.
FNAC has got no role, sir. It has got role if the tumor recurs, sir. If there is recurrence, then to confirm the diagnosis, sir, because we can't grade the tumor based on FNAC, sir.
Okay.
So we go ahead with biopsy, sir.
So what is the other indication for FNAC in soft tissue, sir? Not in this
Recurrence.
patient. One is recurrence. Another indication.
And if there are on USG, if there is any node, clinical node.
Yeah, nodes. Only two places where you do FNAC.
Yes.
One is recurrence. One is lymph node
Node.
metastasis. Any enlarged lymph nodes, you can do a FNAC.
Yes.
So post-operatively, the patient will need RT and also good amount of physiotherapy so that the patient is ambulant, so that he gets a quality of life.
Yes, sir.
So you mentioned diagnosis is rhabdomyosarcoma, but I am doubtful. It will not be rhabdomyosarcoma.
So based on the diagnosis, we started on neoadjuvant chemotherapy. Sir.
What neoadjuvant has been given?
AIM therapy, sir. Adriamycin, ifosfamide, and
So
mesothelin.
rhabdomyosarcoma is a very rare diagnosis in limb sarcomas, and rhabdomyosarcoma is very common in pediatric age.
Pediatric age group.
So in adult, it is very less common, and also it is highly aggressive.
Highly aggressive.
More chemo-resistant in adults, not like pediatrics. So
Yes.
it may not respond to chemotherapy. Okay, I think we covered a lot today. So you like to end?
Sir, I think all good things have to come to an end.
Yes.
We will allow Dr. Narayan to clarify his doubts
Yes.
if there is anything. I think he has come well prepared. Full
Very
credits to Professor Sridhar sir and Professor Faisal sir for preparing, because they sent their PowerPoint almost a couple of weeks before. So, Narayan, I'm sure with reading so much, you would have any doubts to get clarified with Professor Ibrahim sir.
Sir, now the diagnosis turned out to be rhabdomyosarcoma, no, sir.
Yeah.
So to confirm further, before starting ahead with neoadjuvant chemotherapy, can we go ahead with incisional biopsy?
No. True cut biopsy is the only diagnosis. If the diagnosis is not confirmative, if the tissue is inadequate, or only fat is there, or something like that, or the IHC is not conclusive, then if you want more tissues, we can go for an incision biopsy. But incision biopsy is not advisable in sarcomas. It will breach planes. If at all we are going to do an incision biopsy, there are some steps like it should be along the line of future incision. There
shouldn't be raised.
Perfect hemostasis. There should not be raising of flaps.
Yes.
And also no drain should be kept. So these are all some of the components of doing an incision biopsy in a soft tissue sarcoma.
Yes.
So soft tissue sarcoma is a place which is where the criticality of the management comes from the biopsy itself. So wrongly placed biopsy can make the patient an amputee, or even it can kill the patient.
Yes, sir.
So that is very, very important. Okay.
Yes.
Any other doubts? If you want, you can ask. Otherwise, you presented very well. You presented very well, and all the best for your exams.
Yes. Thank you.
Thank you, sir. Thank you. Priyanka ma'am, would you like to add any points, ma'am?
No, sir, it's very good prepared, and sir also discussed very well. And I think all points have been covered now, and wish best of luck for the exam, sir.
Thank you.
Thank
you, madam.
Thank you, ma'am.
Thank you, Ibrahim sir. Thank you, Narayan. I personally thanks to Dr. Sridhar sir also. And thank all the students and faculty. Ibrahim sir, you joined much earlier. Thank you for staying with us all through, even though we called you very late. Thank you very much, sir. With the permission of the faculty and all the participants, we call the session a close. We will meet coming Friday with yet another different case discussion. Thank you very much, sir. Good night, sir. Good night, Narayan. Good night, everyone.